Hello, my name is Christina Chelen, and I'm an ultrasound technologist student at Delaware Technical Community College. And I'm here today to present and discuss a pediatric case study concerning Chiari malformations. I will begin this discussion by telling you what you need to know, talking about the purpose of this presentation, and presenting some statistics related to this disease. We will also be reviewing anatomy, describing clinical appearances, displaying diagnostic imaging, classifying the types of malformations, discussing an individual case study, and explaining medical interventions. Chiari malformations describe a central nervous defect where the cerebellum and brainstem descend into the spinal canal. These defects of the brain are divided into primary and secondary Chiari malformations based on their etiology. Primary and secondary Chiari malformations are then subdivided into 4 types characterized by the severity of displacement of the cerebellum and brainstem into the spinal cord. Patients are frequently asymptomatic in the early stages of these malformations and may not present with any life-altering issues until later into adolescence or even into adulthood. It is possible to detect brain anomalies associated with Chiari malformations during fetal growth, making use of obstetrics ultrasound exams. With the absence of optimal prenatal care and use of sonograms, Chiari malformations are more commonly discovered through computerized tomography and magnetic resonance imaging in the pediatric, adolescent, or adult patient when symptoms become more pronounced. Development of advanced modern medicine has led to more proficient methods of early detection as well as treatment to the serious condition, such as posterior fossa decompressing surgery and electrocautery of the cerebellar tonsils. Key terms, as these are thoroughly explained and defined. Sources to back up the given information are referenced respectively from various educational articles, medical textbooks, and atlases. The purpose of the discussion of this topic is to educate the reader of the normal anatomy of the brain and spinal cord, the causes of Chiari malformations, the symptoms which the patient experiences, the role of medical sonography has in the process of the diagnosis, the appearance of the pathology sonographically, and the methods of medical intervention used to treat Chiari malformations. Another purpose is to tell the story of a specific individual who has lived with this anomaly and how it affected their quality of life. Reviewing the anatomy of the brain and spinal cord is to help the reader understand the normal function of the organs and what complications can occur. Following that, several possible causes of Chiari malformations are explained to raise awareness of the patient's indication for being tested. The role of diagnostic medical sonography is to visualize and record images of normal and abnormal bodily structures. Ultrasound technology, as well as other methods of medical imaging, is used by physicians and sonographers to diagnose Chiari malformations. Finally, after the patient has been diagnosed with a Chiari malformation, they will need further follow-up to determine the severity of their condition and will need surgical intervention to ensure that their quality of life is improved. Here are some statistics related to Chiari malformations taken from Sandra Hagen Ansert. Congenital brain anomalies are rare and occur in only 3% to 8% of all births, including stillbirths. 50% of these births will have a Chiari malformation. Comorbidities account for a high percentage of patients with these malformations, as about 80% to 90% of infants with mild meningocele have Chiari malformations. Another example of multiple diagnoses is that hydrocephalus is present in 90% of cases and to varying degrees. In order to understand the complications of Chiari malformations, it is important to review the normal bodily structures of the brain and brainstem. Chiari malformations largely affect the cerebellum, which normally rests in the posterior fossa of the cranium. The cerebellum mainly controls a person's balance and some basic motor functions. The cerebellum, along with the cerebrum, are separated by protective layers of the brain called meninges. The tentorium cerebelli is the main separation between the cerebrum and the cerebellum. Normally, the cerebellum and parts of the brainstem sit above an opening in the skull that allows the spinal cord to pass through it, called the foramen magnum. The ventricles play a vital role in the cycling of cerebrospinal fluid throughout the brain, brainstem, and spinal cord. Cerebrospinal fluid is the clear fluid that surrounds and cushions the brain and spinal cord. This fluid also circulates nutrients and chemicals filtered from the blood and removes waste products from the brain. Here we have an image displaying some of the structures we've talked about, including the cerebellum, the cerebellar tonsils, ventricles, brainstem, the opening of the foramen magnum, and part of the spinal cord. The clinical appearances are the notable symptoms to which the patient presents. The most common symptom of Chiari malformations is a headache reproducible with coughing, sneezing, bearing down, and bringing excessive strain on muscle groups in the neck or upper chest. Other symptoms may vary among individuals and may include neck pain, hearing or balance problems, muscle weakness or numbness, dizziness, difficulty swallowing or speaking, vomiting, ringing or buzzing in the ears, known as tinnitus, curvature of the spine, known as scoliosis, insomnia, depression, problem with hand coordination, and fine motor skills. As these symptoms are present in more older children, adolescents, and adults, we also need to discuss the clinical appearance in infants. Infants with a Chiari malformation may have difficulty swallowing, irritability when being fed, excessive drooling, a weak cry, gagging or vomiting, arm weakness, a stiff neck, breathing problems, developmental delays, and an inability to gain weight. As mentioned earlier, most patients with early stage Chiari malformations are asymptomatic. When a patient presents with these symptoms, there is indications for neurological testing such as a CT or MRI. However, the optimal method of diagnosing Chiari malformations is to view the first onset of the defects in the fetal patient through sonograms. The next best method would be to observe the symptomatic neonatal or pediatric patient that would indicate further testing. There are two categories of Chiari malformations, being primary and secondary. While primary or congenital Chiari malformations are most common, there are also secondary malformations which are acquired through trauma of the brain and spinal cord. The sonographic characteristics of both categories of Chiari malformations may include a more inferior cerebellum in the posterior fossa, the full view of the third ventricle being concealed by the enlarged massa intermedia, a small posterior fossa space, no cisternum magnum, a misshapen or absent fourth ventricle, the presence of hydrocephalus with prominent occipital horns, and the presence of a myelocele or meningeomyocele at the cervico-occipital junction. In neonate patients presenting with severe holoprosencephalopathy, the corpus callosum is absent due to the immense pressure and displacement of the lower portions of the brain. With the corpus callosum absent, the frontal horns of the ventricles are displaced into a bat-wing shape, as we can see on this ultrasound image. On the left, we have a normal axial view of the neonatal skull, the cranium, yes. And on the right, we no longer can see we can barely see the space of the corpus callosum, and we can see that the frontal horns have curved outward and almost resemblance the wings of a bat. That's why we call it the bat wing shape. Primary Chiari malformations are then subdivided into 4 types of severity, each malformation with its own characteristics. Chiari 1 malformation is the least severe out of the 4 and is simply the downward displacement of the cerebellar tonsils without displacement of the fourth ventricle or medulla. In this MRI image, we can see the spongy texture of the cerebellum in the back of the skull, and we can see this ton-like projection sticking right under it, and we can see that it is descended into the spinal canal. So that's how we would describe Chiari 1 malformation, the cerebellar tonsils displaced into the spinal canal. What can differentiate between more severe types of Chiari malformations would be that in here, we can see this brightly echogenic half moon shape in the center of the skull. That is the corpus callosum. In some cases of Chiari, we will not be able to see it at all, or be able to see just very little parts of it. Formally defined, a Chiari 2 malformation is a displacement of the medulla and cerebellar tonsils and vermis through the foramen magnum into the upper spinal canal, often associated with other cerebral anomalies. Out of the 4 main groups, Chiari 2 malformations are especially unique with their common association with a meningeomyelocele, which is easily seen on ultrasound and magnetic resonance imaging. Type 2 is usually accompanied by a myelomeningocele, which is a form of spina bifida that occurs when the spinal canal and backbone do not close before birth. Spina bifida is a disorder characterized by the incomplete development of the brain, spinal cord, and/or their protective covering. This abnormal finding originates with the failure of neural tube closure during early fetal brain development. The progression of a meningomyelocele in turn presents the proper growth of the brain's ventricles and the posterior fossa bone structures and processes. This results in the suboptimal development of the posterior fossa as a whole, increasing the probability of more intracranial anomalies to occur. The tentorium cerebelli is attached lower than normal, placing more pressure onto the already descending cerebellum. The inferior cerebellum is compressed and displaced into the foramen magnum. So in this MRI image, we are no longer looking at the brain, but we are looking at the spine and spinal cord. And you can see this bulbous shape bubbling up at the skin. This is the myelomeningocele, also known as spina bifida. And this occurs in the presence of this meningomyelocele defines Chiari 2 malformations. So we will still have the displacement of the medulla and cerebellar tonsils through the foramen magnum, but in order to classify Chiari 2 malformation, we need this spina bifida. Chiari 3 malformations involve a more severe type of meningomyelocele, which is a high cervical encephalommeningocele in which the medulla, fourth ventricle, and virtually all the cerebellum reside. So in this image, we can see multiple things going on. First, we notice that the spongy texture of the cerebellum is quite compressed into the bony processes of the skull and is even projecting through the hole, which we call the foramen magnum. We can't even see where the tonsils are. They're so far down into that. And as we mentioned earlier, there's the corpus callosum, and in this image, we cannot identify it at all. It is, this is the agenesis of the corpus callosum, which is associated with Chiari 3 malformation. And instead, we have this very large cystic structure known as the encephalommeningocele, which causes more pressure onto the brain, especially the lower parts of the cerebellum, the tonsils, and the brainstem. Chiari 4 malformations are severe hypoplasia of the cerebellum without displacement. Chiari malformation is also characterized by the severe cerebellar dysplasia and is associated with a hypoplastic cerebellum, small brainstem, large posterior fossa, and a cerebrospinal fluid space that does not cause any pressure effect. So in this axial view of an MRI image, we can see the cerebellum brightly echogenic in the back of the brain. And on adjacent to the sides of the cerebellum, we can see these black cystic structures. This is the posterior fossa. And in Chiari 4 malformations, we will see a large space in the posterior fossa. And in these spaces, there was a collection of cerebrospinal fluid. And not only is there, although there is more cerebrospinal fluid collected here, we have less cerebrospinal fluid volume and perfusion throughout the brain. So instead of having it flow through the brain and doing what the fluid needs to do to regulate the homeostasis of the environment, instead it remains in these collections, causing quite a few problems. Even with the advanced medicine in today's modern age, to ensure the highest quality of life in Chiari malformation patients, the best method is to catch the onset of the anomaly as early as possible. It can be found through a screening exam and multiple diagnostic tests in a symptomatic patient, or it could be found as an incidental finding in diagnostic imaging for a completely unrelated issue. Chiari malformation may not even be the main diagnosis, as this condition is associated with many other cerebellar and spinal cord anomalies. As long as the presence of abnormalities detected, there is a higher probability of an effective treatment. In the case of Shannon Hudson Terry, it took over 5 years of living with Chiari malformation before her symptoms started to appear as notable. She lived with severe headaches and anxiety, later followed by depression. After, she began to lose the use of her hand and leg. Shannon did not undergo any specified neurological testing until her symptoms had progressed to a severe level for concern. Once the diagnosis of Chiari malformation was confirmed, there were limited options for her. In many cases, surgery is the only treatment available to ease symptoms or halt the progression of damage to the central nervous system. Shannon's treatment involved undergoing decompression surgery to relieve some of the pressure on her brain, nerves, and spinal cord. The surgery proved to fail at providing any relief from Shannon's worsening symptoms. She continued living with her symptoms until eventually her condition became critical. Shannon Hudson Taylor lost her fight with Chiari malformation about 9 years ago. If diagnosed early, there are effective treatments that can be given to a patient with Chiari malformation. According to the National Institute of Neurological Disorders and Stroke, the most common surgery to treat Chiari malformation is posterior fossa decompression. Shannon underwent a similar form of this decompression surgery to provide more space and decompress her displaced cerebellum and spinal cord. It involves a craniotomy of the skull and the removal of the spinal lamina. The surgery is performed to reestablish proper flow of the cerebrospinal fluid. The surgery also involves the surgeon making an incision in the dura protective covering of the brain and spinal cord. If after this incision, the brain and spinal cord areas still appear compressed, the surgeon will then perform an electrocautery to cauterize and remove the cerebellar tonsils, which have descended to the spinal cord. In Shannon's case, the surgery did little to relieve her symptoms, possibly because of the late onset of her diagnosis. In conclusion, the topic of Chiari malformations has been extensively discussed along with an overall view of the normal and abnormal anatomy of the brain and spinal cord, etiology of Chiari malformations, the symptoms which the patient may or may not present, the role of medical imaging such as ultrasound, and the appearance of pathological findings using ultrasound. It is a rare pathology of the central nervous system, which in turn needs surgical intervention in symptomatic patients to relieve their suffering and preserve the function and quality of their lives. The most effective measure of treatment is early onset diagnosis. Here we have a list of my references that I used during my presentation, including links to the images I used, and any other links used in my PowerPoint were from the free stock file, the stock image file. Thank you so much for listening.